Adherence there is a bit missing because we do not know whether the actual protocols are adhered to before processing samples. Again, our adoption of technology is quite low when we think about how we are processing this work. The reason why this is so important is we appreciate the need for taking quality cultures, because if you do not have quality cultures, you definitely will not get the results that you need, isn't it? And so the patient will stay in the hospital longer because we need to take another culture. Again, that patient we may not keep them safe because we've been discussing patient safety issues here. Think about a neonate that you need to prick twice or thrice because you're collecting another set of sample. But again, the question, who bears the cost of the second sample? The patient is bearing the cost, yet probably it's an error in our system when we do not actually grow positive culture from it. And so, what is our problem? And what was our problem? When I got to Kijabe, we were doing surveillance for antimicrobial resistant antimicrobial resistance among the WHO priority pathogens. And specifically for blood cultures, we noticed that there was a problem with contaminants. And our average was at 6%, 6.7%, which was way higher compared to CLSI recommended guidelines of less than 3%. And that was a huge issue. And so we decided to design a quality improvement program to help address that. But as you can see here, we put up a team together to understand the gaps, to sort of like do root cause analysis and design the intervention. Then we trained phlebotomy teams, and then we saw a very good drop in the number of contaminants to less than 2%. But then we again saw a steady rise as time went by. And that is a huge problem. So we decided to sort of like do a refresher training, and actually multiple trainings while we monitor. And then we still see a steady increase in the contaminants, way higher than we expected. And so we wanted to understand what could actually be an issue. So we designed a study within a study, and that is the problem that we then identified, that there was an issue with aseptic collection, right? And also a big issue on turnaround time. And they came out as one of the problems that we were seeing. And so we decided to hold on a bit so that we can intervene well. And when you look at this run chart, the graph is not even steady. It's not like this side here, meaning that there are quite more system issue-related challenges that we needed to, again, sit down together as a team and think, how can we address that? Now, this is a study that was published in 2010 in the Journal of Infectious Diseases, and the big news from this study is in the pre-analytical stages of the phlebotomists that were being observed, 194 phlebotomists, none met the standards. Okay? It's available in the Infectious Disease Journal. And so we designed a study to just understand what is happening. So this is what we will talk about. So it's a descriptive study. The population were majorly phlebotomists, though we had a few nurses and clinical officers who participate in blood collection, especially the pediatric emergency critical care clinical officers in the emergency ward. And also we have some ECHO, emergency critical care clinical officer who collect the blood samples. And so we have a standard WHO guideline on how samples should be collected. And because I am not a phlebotomist, neither am I a lab technician, I had to sit down with experts to know which tool could answer that question in our QI. And we blinded the observations just to make sure that it's not biased and someone does not do the right thing, all right, when they are being observed. And we retrieved the turnaround time using our HMIS system. Of course, we were able to notice a few more gaps. We were able to think about TAT, get the mean, the median, and the standard deviation with some chi-square tests and ANOVA to just test correlations. You can see this because this is the tool that we designed on REDCap. And so these are the results briefly. We had 92 phlebotomists observed. They were the majority part of the population, meaning that these results are really skewed towards them, and they were primarily our target population. A few nurses were observed, but it was good that we had more phlebotomists. And these are the issues that we found related to patient safety concerns, and I'll throw your eyes to two key things in terms of collection. Now, when you look at the red part of this graph, the green part says it is correctly done. So when it comes to aseptic technique, tourniquet time, tourniquet application, vein examination, all these are correctly done, the green side. But when you look at the red, it is incorrectly done, all right? Now, in quality assurance or in quality samples, you want everything to be green, isn't it? So I'll throw your eyes to two things that are key for discussion. One is hand hygiene. So you notice that 26% of phlebotomists practice hand hygiene before collecting the sample. And this was consistent with another study that we were implementing on hand hygiene compliance, which was at 26% overall in the entire hospital. So this is a separate study, all right? And this is a comment that I got from people who are observing. So one of the observers said the phlebotomist put cotton on the patient bed while collecting the sample. So this is someone observing them, and they notice such kind of things. In our setup, there is still collection from one site, and we are questioning the issue of cost versus the evidence for outcome, and we need to think about that because there's an argument that if you collect blood from two sites, it means the patient pays more, and so there's a standard way of collecting just from one site. This is a discussion we are having, and we are rolling out another study to just even pay for some more sample collections, and we see whether we'll have better outcome. But again, we do not have sterile gloves, we use clean gloves. And sometimes part of the comments we have in the observations, we had paper gloves used for collection. We have some issues that were related to sample integrity. Again, the green means it was correctly done. So we were looking at blood volume. Is it correctly, is the right volume collected? 76% correct blood volume. Order of collection, if a patient has multiple order, maybe chemistry, and then they also have microbiology, we have 31% that was not correctly done. So it means they collected chemistry before microbiology, for example. Recommended mixing, the way you mix the sample, these are really from the tool that we were using. And again, hemolysis assessment. And again, when you look at the red, you need to think about this because we can't ignore that these are important things to think about if we want a quality sample. Again, we talked about that, the issue of how the sample is collected. This is a comment I got from one of the people who are observing. They said sample was collected during IV line placement by a nurse to avoid double pricking. Look at that. So when you're placing the IV line, you know the way you the way you aseptically prepare the site is not the same way for IV placement. But then they just collect within that time. So we need to think about such issues. Our sample outcomes, we only 13% had a true pathogen, so a true positive pathogen. This is from the 78 observations that we made. 66% no yield, so they didn't grow anything. So we need to think about these patients. How were they treated? Did we have multiple orders again and things like that? But again, we had staph other than Staphylococcus aureus, that is the contaminants at 14% again. This is very high, all right? So we need to think about this population. But again, we had some missing results. So a sample was collected, but it was not posted. This is something we need to think about in terms of the things we do in the lab. We tracked turnaround time, and I'll not spend a lot of time here because there is a huge gap when it comes to documentation for this. And the huge gap in documentation is because the documentation system in Kijabe is more like a double documentation system where there is receiving the sample in the EMR system, and again, documentation in the patient file when the sample arrives in the lab. It was difficult to track that because the means we were getting were very unreliable, all right? Were very, very unreliable. However, some test of correlations, we noticed that aseptic technique was directly correlated to, had significant effect on the sample outcome, all right? So think about contamination or positive growth. So I'll spend some time to discuss some of the things that are key. So this is more like the process the patient goes through when they come to the hospital. And when we think about TAT, we need to ask ourselves, is TAT from the time the patient, the sample is ordered, or from the time the patient left their home to come to the hospital, all right? When you think about the, the entire quality of care continuum, when does TAT begin? And how are our processes? Like Kijabe has 4 major rounds for sample collections, for blood sample collections. And there's like a gap in terms of the time when they go to collect the sample. And is that fair to the patient? Are such systems helping our patient get better results? All right? But something that we should appreciate, that you can trust our lab. At this stage, in terms of analysis, you can trust us. Why? Because our EQA results, we are meeting expectations. And we had a separate study that I will just bring up to show you our sensitivity rate, which was at 93%, a Pfizer-funded MR study where we were shipping samples for sort of like just to see whether what we isolated is true. And so these are some of our EQA results that we've just received recently. 98%, very good, we are meeting expectations. 100%, we are doing very well. Again, 100%, we are doing very well. But again, this is a different study that we did, and we were shipping samples to South Africa, the national lab. And if we isolated a bacteria here, 93% we could isolate it there. So it means that we are doing very, very well, all right? So this is something that we first need to appreciate. So on the analytical stage of our lab, we are doing very well. However, the question is, when does quality begin? All right? I propose it begins there, guys. It begins from thinking about the phlebotomy, who is collecting that sample. But even not that, thinking about the patient, all right? And I will draw your attention to that for a few minutes. The patient is part of the continuum of care. Imagine, and we appreciate, let me say this first. We appreciate that if a sample is ordered for bacteremia, you need to collect it immediately when the symptom is present, isn't it? But why wait for 4 hours later? That is the question. If that was your baby or it was your mother, would you collect the sample immediately? And so we need to be kind to our patients, all right? We need to care for them, and we need to think about the cost implications. We need to think about if we didn't grow anything in that sample, yet the patient is presenting with symptoms, what will happen? But again, we need to provide a patient, an environment that the patient feels safe and feels if I need this sample, it will be collected immediately. Because sometimes even that collection is forgotten. But we also need to think about the chain of custody. When you've ordered the sample and you've collected it, how long does it take to arrive in the lab? Our average TAT was at 2.8 hours. Our average TAT from the emergency unit is 4.2 hours because they want the patient to pay first before they process the sample. But we know if the sample waits for more than 2 hours, you'll grow nothing. Isn't it? So are we offering quality care? So my proposal to all of us today, we need to strengthen QA at the pre-analytical phase. This is a study again that is published. It's more like an opinion paper that speaks to, are we getting better at the pre-analytical phase or just better at measuring it? Well, this is a study that is published in Europe, but we need to ask ourselves, are we even measuring it? in Africa, who knows their contamination rates in their hospital? I was hanging out with phlebotomists the other day and asked them, what is the current contamination rate? And nobody knew the rate. What was it last month? Nobody knew the rate. So we are not measuring it. So before we think about reducing, we need to think about whether we are measuring and learning from our data. These are my closing remarks, guys. First, phlebotomy is not just about drawing blood. It is about drawing the line between contamination, clarity, between delay and diagnosis. Every drop of blood drawn with care is a step towards healing. This is when we care about the patient, so that we do not look at this as a blood sample. We don't look at humans like tumors. Have you ever heard surgeons say, did you see that tumor? Did you see how massive it was? All right? We need to think about them like people who deserve quality care. And lastly, every blood drawn is a lesson. We need to learn from our data. We need to take time to reflect through what we are doing in the lab. And we need to take time to repeat what we are doing with purpose, and refine our processes and think whether it's making sense. And so when we do that, phlebotomy becomes a pathway to continuous quality care and safe care. Thank you.